Now I'm going to turn this over now to Dr. Hugh. Um, he's the director of the Center for Healthy Aging Research, associate professor and chief of cognitive neurology at Rutgers. And I need to stop sharing and let him share. Allow. Okay, Dr. Hugh, you should be able to share your
Great.
screen now.
Can you see my screen?
Yep.
There it is. Yes, sir. Thank
Great.
you.
And thank you for having me. And I think it was a true pleasure to get an invitation because I'm actually a Cranbury resident.
Oh,
And it's very excited. I'm very excited to be here to talk to to people, to find people from my hometown about something that's near and dear to my heart. I think there's some interest in hearing about preventing Alzheimer's disease, but I think we've got to, in order to effectively prevent it, we have to know what it is and how we actually diagnose it. And before we get to the prevention part, so that's kind of the how the presentation will go today. And generally, when we give a talk, whether it's a scientific talk or a community talk, we have our disclosures for transparency purposes. And I am primarily funded by the NIH, but also am supported by a number of foundations. And I want to thank the Women's Club for giving us a donation and for to support our program. The host has spotlight. Okay. Um, I've also done some consulting and the none of
You're supposed to talk about Alzheimer's.
yes, and then none of the consulting is going to buy us much of the talk tonight. I also have a number of patents, primarily assigned to the universities, and I have made very little money from any of these inventions assigned to the universities. And a lot of the work, again, like many things we do, did not come from me alone. I have a sizable team at Rutgers and at my previous institutions. I also have a number of other collaborators at Robert Wood Johnson Medical School, New Jersey Medical School. I'm housed within the Institute for Health, and there are many, many groups there. And then finally, it's always important to thank that our patients, families, and healthy volunteers without whom this work would not be possible at all. So when we talk about Alzheimer's disease and related dementias, I like to start with some numbers. So there are currently estimated 6 million Americans living with Alzheimer's disease and related dementias. And the 6 million trailing number is a little difficult to predict just because of underdiagnosis across the health systems. And again, there are probably at least 50 million people around the world living with one of these conditions. The lifetime risk used to be said to be about 35% until this year, when an updated study came out and said that your lifetime risk is now 47% of developing one of these conditions as one ages, and probably because of the people are living longer. And this is not an equal opportunity disease, and the people who are minorities in the United States face twice the risk compared to non-Hispanic white older adults. What is striking is that for every person with Alzheimer's disease-related dementia, their care costs on a yearly basis beyond regular care, going to the regular doctors, getting your cholesterol checked, getting your blood pressure checked, getting your cancer screening, is 25 to $35,000 extra. And in contrast, the NIH on average invests $535 per person. I didn't miss a K there. It's just $535 per person per year to study these diseases. So putting it into another way, for every $50 spent on care of these diseases, only $1 is spent on researching for a cure.
oh yeah.
So when you think about that, it is not that research is not a waste. And I think there's been a lot of talk about how research is a
This is our
wasteful expense. but $50 to the dollar, $1 is not a waste.
I could record it because I would like to see it. It's on Alzheimer's.
Yeah, maybe we can have. I'm not sure. Maybe people who just came on later. Maybe we can mute.
Yeah.
Thank you. So, what is Alzheimer's disease? The definition of Alzheimer's disease actually has not changed since 1906, when Alois Alzheimer, picture here, described it. It is a set of brain changes that can only be seen under the microscope. These are some of his original drawings in the middle. Here are the plaques that people may have heard about, the amyloid plaques. And with more advanced staining techniques and microscopy, we can see them easier nowadays. But the shape and the format really hasn't changed over 100 years. And then the other component is the tangles, the tau tangles. These are inside the brain cells. Each of these is a little brain cell, and it's filled with these. It looks like somebody took a Sharpie and colored them. And again, with advanced microscopy, we can see them easier, but it doesn't look any different in general compared to what Alois Alzheimer described over 100 years ago. And nowadays, we really consider Alzheimer's disease to have 4 main features, and sometimes we consider these as the 4 horsemen of Alzheimer's disease. There's the amyloid plaques, the tau tangles, which we saw on what Dr. Alzheimer's described. There's also inflammation, which we now better understand, as well as brain cell loss, with all these insults on the brain cells. One thing that we have been working towards is reducing the plaques, the tangles, and inflammation, because right now there is not a way to reverse the brain cells loss once the brain cells are dead. So anything in terms of prevention has to do with slowing down the insults so that the remaining brain cells can do better. However, despite all these better understanding from a scientific perspective, our ability to diagnose Alzheimer's disease just by you seeing a doctor has not improved dramatically over the past almost 50 years. These are some of the numbers from the National Alzheimer's Centers. And for those of you who are savvy about sensitivity and specificity, and what these figures tell us is that we're able to pick up Alzheimer's disease fairly well. But when we say somebody doesn't have Alzheimer's disease, our accuracy there becomes relatively poor. And putting it another way, going back to one of the first slides that we talked about, when we say there are estimated 6 million people with Alzheimer's disease in the United States, of the 6 million, 1.2 million of them don't have the disease. And then there's another 1.1 million walking around having been told they don't have Alzheimer's disease who actually do. So that's 2 million people around walking with a wrong diagnosis. And that actually outnumbers a number of diseases such as Parkinson's disease. Just think about it. There are more people walking around with the wrong dementia diagnosis than there are people with Parkinson's disease. That's something. It got so bad that at some point in time, people said, and initially I laughed, but then I had to think seriously about it. So if you just assume everybody walks to the door as having Alzheimer's disease, you're not a whole lot worse off in terms of the overall accuracy. It's a difference of 3%. No doctor will ever say that, so you have a memory loss, I'm just going to say you have Alzheimer's disease. But numerically, you end up with a pretty similar accuracy. And part of the challenge is how we look at the brain and how the brain responds. So if somebody has a sudden change today, if, for example, God forbid, when I'm speaking, I suddenly stop speaking, I suddenly can't move my arm, the doctors are very well trained to start thinking what could be going on. Is it a stroke? Is it a tumor? Is it an encephalitis of an infection of some sort? However, if the brain changes are very slow over years, each person's brain can respond and compensate differently. That becomes much more challenging to figure out what the underlying cause is. And a lot of times when we talk about Alzheimer's disease and related dementias, these are the other possibilities. Each of these can give a picture that clinically looks very much like Alzheimer's disease, but without testing, sometimes could be very challenging to tell apart. And when you look at this list, you're going to see the word dementia come up. And then I've purposely avoided using that word so far when talking about Alzheimer's disease, because one of the most common questions I get asked is, what is the difference between Alzheimer's disease and dementia? So again, I'm going to stick to my recipe there. Alzheimer's disease is a collection of these four features: the plaques, the tangles, the inflammation, and resulting brain cell loss. And there can be memory issues associated with it. Dementia, on the other hand, really refers to having enough brain cell loss, regardless of the reason, such that when you're doing pencil and paper testing in a doctor's office, you're not doing as well as you should. And on top of that, if things continue to progress, people are going to have functional issues, such as forgetting to pay bills, forgetting how to do the work they've been doing for a long time, or making a lot of mistakes, getting into car accidents excessively, in a weather like this, going out making inappropriate decisions to go out in shorts. Although my 12-year-old tried to do that this morning, and then finally getting scammed. Each one of these things in isolation is not enough to say something's wrong. But more often than not, it's a collection of many of these on regular and recurrent basis that makes us believe that their brain is really experiencing a dysfunction. Other than dementia, people, unlike stroke, people don't suddenly wake up with dementia one day. People go through a phase where there's less deficit, but then the frequency and the intensity will also increase over time. And that phase is what we call mild cognitive impairment, or MCI, like the telephone company. So again, mild cognitive impairment and dementia are how one is doing, and Alzheimer's disease is the underlying cause. So how do we, going back to 2 slides ago now, how do we actually improve how we tell whether someone has Alzheimer's disease or not? And one of the greatest advances over the past 20 years is this entity called biomarkers. Biomarkers, I love the word biomarker because you always remember what it means. It is a marker of the biology. There's nothing fancy about it. It is not your blood pressure. It's not a physical exam. It's how you do. It is a measure of the plaques. It's a measure of the tangles. You're already using biomarkers in many senses. They're just not called that. So people get liver function tests. People, when you're taking medicines, COVID serology tells you that your body is building an immune reaction to acute infection. There's the little cute kid on television advertising that you can detect cancer DNA in the stool. So these are all biomarkers. And good biomarkers should do 2 things. You should be able to separate disease from health and distinguish between specific forms of diseases. And when it comes to the brain, we rely heavily on biomarkers because we work with a unique organ. If you have a breast lump, the doctor will likely recommend that you do a needle biopsy after various types of imaging studies. If you have a suspicious looking mole, again, they will likely suggest a biopsy. For us, it's harder, not impossible, but harder to perform a brain biopsy. And from the perspective of convenience, it's relatively more convenient for the neurosurgeon than the person undergoing the knife, because the neurosurgeon will come out fine, but anybody who has a brain biopsy generally loses a little bit of function one way or the other after the biopsy. So instead, we rely on two alternate methods. One is the cerebrospinal fluid that is obtained through a procedure that's very similar to an epidural when one woman is giving birth or when one has back pain. And the other one is a fancier PET scan, not the regular sugar PET scan that was done for a long time, but very specific amyloid plaque PET scan or tau tangle scan. And again, all these things are to detect whether you have plaques and tangles in the brain. In the spinal fluid, we've also advanced to the degree that we can now diagnose Parkinson's disease and also one form of the frontotemporal lobar degeneration, which won't be the focus today. Maybe I'll come back later and talk to you about them. So why is this important? Why do we need to get accurate diagnosis? So this sounds silly, but our field has actually been debating this for the past 40 years. Number one is that we need to identify things that are more easily treatable. Vitamin B12 deficiency, low thyroid, and HIV, even though it is a serious illness, it is treatable now versus Alzheimer's disease, it is less treatable. And despite all our talks over the years, we still see people being diagnosed with Alzheimer's disease due to low thyroid. Still happens. Number two, we can predict what will come next. Depending on what the underlying disease is, the future it can be reasonably predicted in terms of what may come next. If somebody is diagnosed with Lewy body dementia, which is something that Robin Williams had, and his wife has worked very hard to bring this to the forefront of awareness. People experience hallucinations very early and falls and very scary acting out dreams, which are actually relatively benign. If somebody has a form that's related to dementia that's related to ALS, people progress quickly. They will have swallowing problems, and they can actually have sudden death because they suddenly stop breathing. And again, for some of these conditions, we can't change the course, but we can eliminate the element of surprise. People often ask me, what are my children's risks? Knowing what disease it is makes a huge difference in better counseling the next generation. And then finally, we can better discuss the risk benefits of medications. Just as one example, Lewy body dementia actually responds very well to one of the Alzheimer medications. But when given to another condition, it will actually make people worse. So again, just customizing the treatment. But when we talk about treatments, what's important is knowing what treatment options there are as the landscape has changed dramatically compared to 4 or 5 years ago. When we talk about treatments, this is a figure that we use both in the hospital as well as in scientific meetings to kind of conceptualize decline. So on the bottom here, there is time. So the further right you go, the more time has elapsed. On the y-axis here, it's the degree of memory and issues. So the further up you go, the worse the memory and function are. So certainly there's a large range of variability between individuals, but we kind of conceptualize as a line like this where we do nothing. This is what happens. For medicines that were available from the 1990s until the 2020, 2021, all we had were what's called symptomatic medicines. The symptomatic medicines are the donepezil, the memantine, the trade names Aricept and Namenda. They improve the symptoms some, but they don't slow down the disease. So when we look at on this figure, the first part is that there's a little dip. They improve the symptoms some, But then as time goes on, people on these medications with Alzheimer's disease will continue to decline at a similar rate. And there will be a slight acceleration at the end because these medicines begin to be ineffective. On the other hand, what people have been working on for 20 years or so is something that can slow down the disease. And for the first time, we actually have three medicines that seem to do that. And what slowing down the disease looks like is this. So because it slows down the disease, it only does something to the plaques and the tangles. It doesn't do anything to memory and function. So initially, it's going to feel like there's no difference whatsoever. But the greater differences will be seen a year and a half or 2 years down the road when the trajectories start to diverge. It's always difficult at an individual person's level to say what would have happened if you weren't on the medicine. That's why we do the clinical trials to figure out the group level differences. Within individual, there is always a question, but that's also very similar to some of the other situations, such as when you have COVID or another infection. Do you take the antiviral antibiotics? You don't know how you'd have done if you didn't take it, but then based on the clinical trials, people who take it end up better than people who don't. There is a little bit of faith, a leap of faith, but then again, I think based on the data we've seen, this is a reasonable assumption that people will experience benefit. And the slowing down is about 25%. And if you think back I imagine some of your math teachers in here or accountants, and they were the four horsemen of Alzheimer's disease. If we can effectively eliminate the plaques, we can slow down the disease by 25%. So numerically, it was kind of a coincidence. And what we hope in the future is that with each class of drug targeting other changes in Alzheimer's disease, we can further flatten the curve to the point that eventually with stem cells or something else, we can reverse the brain cell loss. These are the three drugs that are FDA approved. The first drug that's across the first row has been pulled from market. But I'm just showing you all the options, all the available drugs here to really say that they are very similar to each other. On the left side are the amount of plaques in the brain, change in the plaques in the brain. So a flat line means no change, and downward line means reduction in the plaques. So all three drugs reduce the plaques very effectively in the brain. And on the right side, the manufacturers like to flip things around to confuse the readers. So different colored lines, different arrangements. That's where you'll see these upside down. I flipped them just so they're all aligned. And then on top is the placebo. On the bottom is the drug. So during the treatment phase, it's all the same. There's a slowing down progression by about 25%. With the first drug, that with the longest follow-up, when they had people who took the drug who had to stop because it wasn't available at that time, come back, the benefit persisted. So, and again, this is not the case for the symptomatic drugs. If you stop the symptomatic drugs, this line would just catch up to the one on top. And these are true disease modifying drugs. They change the underlying disease so that overall, even if you stop at this point, the benefit remains over the course of on average, at least a year and a half. So now to the core part of the talk. I think there's a lot of Alzheimer's disease is a serious illness. Many of us are impacted personally, professionally by it. And one of the greatest questions in the field is it preventable if it's so difficult to treat? And that is a very challenging question to answer. An easier one, relatively speaking, is dementia potentially preventable? because it is easier at the population level to understand, to detect dementia than to confirm that dementia is due to Alzheimer's disease. As a result, I don't think I will be able to fully answer the question posed to me tonight, but I hope that we can provide you with some data, some studies, and some evidence to show that at least some portions of dementia, be them Alzheimer's or something else, is preventable. So over the past 10 years, a panel of experts convened by the Lancet Journal in England, in the UK, have reviewed all the available epidemiological studies from different populations around the world and asked the question about what proportion of dementia, Alzheimer's or non-Alzheimer's, is potentially preventable and they are potentially modifiable. And these are some of the factors that have shown up study after study after study. There have been a number of these figures, and the main themes remain the same, even though some of the numbers will fluctuate over time. First, in early life, the biggest thing is education. Educational ascertainment and exposure are highly protective for the brain. They may not change how one declines after Alzheimer's disease sets in, but they will delay the onset of symptoms of dementia from Alzheimer's disease. And in midlife is where you see the number of these circles increase by the year. Because it used to be thought that Alzheimer's disease was a disease of late life. But because of the advances in the biomarkers, we're now able to detect these changes in people in their 40s and 50s and 60s, long before the symptoms begin, so that we know this disease in some ways is a lifelong disease, that it just doesn't show up symptomatically until later in life. So some of the disease modification, some of the slowing down of the disease should maybe begin in midlife. The biggest news that over the past 10 years is probably hearing loss. It seems that when people incur hearing loss in middle age, their risk for dementia later in life goes up dramatically. Is this because of sensory deprivation in midlife that is depriving the brain? Is this because of social isolation, which you also see show up in late life? It's not known. But I think for most of us, we're recommending that if you believe you have a hearing issue, please get your hearing checked. It's a simple test. And hearing aids, even if you don't use them all the time, probably help because they are a simple and cheap way to try to do something to reduce the future risks. Traumatic brain injury is 3%. And again, I think this is where, lifestyle choices matter a lot. Some people still play contact sports in middle age and older age, and other times people ride bikes without helmets. So if you do decide to ride a bike, please wear a helmet. Depression is a modest risk factor from midlife, and smoking, and this probably matters more in the rest of the world than the United States, and there's still a lot of smokers in outside of the United States. But smoking remains a risk factor for dementia, probably more vascular dementia than Alzheimer's disease. And the biggest risk factor in late life is social isolation. And this is not only an individual's problem, it's a societal problem. And this is something that clubs like this will really help society solve. I'm sure that you've all heard that with the introduction of social media and other things, people stop getting together. And this is true at work, this is true at play. And I don't think any neuroscientist would seriously consider tweeting a formal social interaction our brain is designed for. So I think please still get together with people and please continue the old ways of socialization because it helps. What's interesting and is the role of cardiovascular disease in the prevention of dementia. And this is where the data from the United States and elsewhere start to diverge. And about 10 years ago, there were serious reports that talked about the decline in the rate of dementia in the United States, that we were effectively preventing Alzheimer's disease. But when people look deeper into the numbers, it turned out that Alzheimer's disease did not change, but the aggressive intervention from the cardiologist reduced the risk of vascular dementia across the US. And this still needs to happen in the rest of the world, but in the United States, the American Heart Association, American College of Cardiologists, they have done a great job at reducing the cardiovascular risks. And both in cardiovascular risks apply for the heart just as well as the brain. So the risk of vascular dementia has significantly declined. We still have some way to go, but then again, that has changed. And up in 2020, the estimate was that the contribution from non-smoking cardiovascular fitness was only 6%. 6% is actually less than hearing loss. And we spend probably 100 times more research dollars and clinical dollars on cardiovascular fitness than hearing. However, I suspect the cardiovascular people complained, so the 6% got bumped up to 14% in 2024. So we will see in 2028 how the numbers pan out, but I imagine it's going to be closer to 6 in this country than 14. Within all these potentially preventable risk factors or modifiable risk factors, I want to spend a little bit of time talking about what we do know about treating them and reducing the risk of dementia. The first one is the big one, and a few years ago, this was even still controversial. Cholesterol medicines, especially if your cholesterol is high. So this is a study that just published this year that reviewed all the clinical trials around the world to see what the relationship is between using the cholesterol drug, lowering drugs, and future dementia risk. And I want to show you this bold line here of 0.3685. So what that is the relative risk of dementia. So if you've been taking a cholesterol medicine for 3 or more years, your risk is reduced by 65%. 65%. If we combine people who've only taken it for, a few months and a couple of years, short of 3 years, the overall reduction is still 24%. So this is a really important thing to do. And you can look at the years. These have come out over the past 15 years, some of these studies. So really that there is a strong reason especially for people with high cholesterol already, to be on cholesterol medicines. I'm going to answer the question that hasn't been asked yet because I'm asked this all the time. But when I started the cholesterol medicine, I felt more foggy. But my friend says that when they started the cholesterol medicine, their memory just completely disappeared. And our general recommendation is that try another cholesterol medicine, just like other medications that have side effects. Just because one has a side effect doesn't necessarily mean another one is doomed to repeat the same thing. So overall, these are tens of thousands of people around the world. Taking a cholesterol medicine reduces your dementia risk. Along the same theme, this is a study that was done in the United States as well as Canada, aggressive blood pressure control. So here what they did is that they either use education, and then so most people's blood pressure was about the high upper numbers 135, hovering about 135, which by no means in the old scale would say they are extremely high blood pressure. But then they have this aggressive group where they're trying to aim towards 110 to 120. The goal was not to get people there. The goal was to try. And when they did this, compare these two groups, the findings were so dramatic that they had to stop the trial right here because it would be unethical to continue without telling these people up here that you need to treat your blood pressure more aggressively. And when they looked at what is called the cohort phase, and when they were people in participating in the trial were released back into their general doctor's care, and what you can see now unexpectedly is that the blood pressure rose for this group. One could argue that it's really the frequent contact with your doctor that customizes your blood pressure treatment that makes this difference. But either way, it doesn't matter. The outcome is the same. And these differences actually get bigger over time when people are followed 7 years beyond the trial. It's almost a twofold difference in terms of the intensive treatment versus the usual treatment. So again, treating the cholesterol and treating the blood pressure. Now we're going to go into some preventions, which being very confusing. And I imagine that some of you have heard this and some of you may even participate in these studies. So it was in the late 90s that observations from the Women's Health Initiative, the national study of women, that showed that those people who took estrogen had better brain functions at old age. And this obviously raised a lot of concerns as well as excitement in the sense that, we now understand why women have higher rates of dementia than men. It's because of loss of estrogen, and we have all the drugs already that are cheap and available. But it turned out that when they actually turned this into a treatment for prevention, so for women who have entered menopause, not on estrogen, when they started them on estrogen, they actually did worse. These are the filled circles here compared to people who were not on estrogen. So replacing it in the literal sense of the word after menopause has begun didn't seem to help. But realistically, very few people did that. More people stayed on estrogen therapy during the perimenopause menopausal phase. So another study tried to emulate that and then say and ask the question, what happens if you stayed on the estrogen replacement? And without going through the details, the message is the same, that there's not a huge difference because of sample size, but if anything, continue on estrogen for prolonged periods of time actually increase your future dementia risks. So what we always say now is use estrogen during the transition period for symptoms of hot flashes and other things. But, if your doctor forgets, which happens quite a bit, and forgets to take you off the estrogen, ask to be taken off the estrogen, especially as you approach the 60s and early 70s. And here are the negative results. And then, you're going to hear me recommend these things. You're going to hear others recommend these things. But the study results are resoundingly negative. Number one, exercise, aerobic exercise. Aerobic exercise was run in one of the largest studies. I actually knew the doctor who ran the study, and after this, she was so frustrated she joined pharma. But essentially, exercise for a whole year and a half did nothing. There is a caveat in that when they videotape all the exercise sessions, And when they went back and watched the video, these were older women, older men getting together to exercise at the local Y and other gyms. When they watched the videos, there was about 15 and 20-minute warm up. The actual exercise probably only lasted 30 minutes. And then there was a period of socialization followed by donuts. So, is this a truly negative result? It's hard to say. But this is the reality of these studies that, we're not working with mice, we're working with people. And was that necessarily harmful? Probably not. They were preventing dementia according to the social isolation aspects. But this study was a resounding negative study. The other one is another resounding negative study is the Mediterranean diet. And I think it's being talked about a ton. And then when they started people on Mediterranean diet here as a modified form called MIND, there really was no difference versus regular diet. It doesn't mean that you should, eat as many wings as you want this Sunday and Super Bowl. But then again, kind of the aggressive restriction to one particular form of diet did not seem to help more than just regular diet advisement and education about eating healthy. So all the niche diets out there, they probably don't work, but still eat healthy. There are some potentially promising studies that are smaller, but they're ongoing in both here and elsewhere. So the first one began in Finland. They said, well, if exercise didn't work, if the diet didn't work, maybe we'll just put everything together and do what I call a witch brew. So we don't know what is doing what is the secret sauce, but as long as it works, it works. So they did counseling for lifestyle changes in diet. They did 2 to 5 times per week of aerobic exercise, 1 to 3 times per week of strength training. And according to all the studies, strength training probably does more for the brain than actual aerobic exercise, plus cognitive training. This is for 24 months. And this was felt to be a positive study because what you can see the figures that people had better processing speed. What is processing speed? Processing speed is how you do the cognitive tasks, and then this is in a way and reimagining a practice makes perfect. If you've been training for it 45 minutes a week, you end up doing better. However, this didn't really translate to an improvement in memory. When they look at the memory for these people who were underwent this intensive multi-dimensional training versus not, memory was exactly the same. The Japanese and other and then scientists from other countries are also trying to replicate some of these. And here's the recent study from Japan, where they actually were more prescriptive in terms of what you had to do. So it's 15 minutes aerobic exercise, 20 minutes of strength training, and then they added a 20-minute per month of group meeting. That's perhaps again for socialization plus tablet cognitive training. And this is significant, but then and again, how much of this because you're trained to take the test that determines how you do, that has to be figured out. But again, there are some encouraging trends that combining them may be better than just doing each one of them alone. One thing that is perhaps more exciting is looking at a study that from Baltimore when they looked at what happens to people's brains when they did something. Up until now, they primarily looked at how they perform on testing. And performing on testing can be biased by training, but your brain volume is difficult to fake by training alone. So when they look at what's called the experience core, I'll go into the detail a little bit. It turned out that people in the experience core experience less brain volume lost over time especially in men. And then what this involved is really partnering retired older adults with the local schools to improve literacy, to improve engagement. And on the one hand, it also helps with the local schools. On the other hand, it preserved the brain volume against aging-related loss. So this is quite remarkable that before the pandemic, the AARP was in the process of broadening the offering of Experience Corps beyond Baltimore. But certainly with the pandemic, that's being, slow in coming. But again, there's something here that and I can't tell you what it is. I think part of it may be something that we were talking about is difficult to measure, which is purpose. And that there's something here and when I mean purpose, I mean purposefulness. And then so there may be something here that, if you have a purpose in life, your brain will be able to deal with the trauma of aging better. So with the remaining time, I just want to briefly talk about something, and with this has been in the media quite a bit lately, and you're only going to hear more. When we talk about prevention, there's a large business in telling you what your risks are, and the higher risk you are, the more you need to prevent. And about a year and a half ago, this became a direct-to-consumer test that you can order without your doctor's prescription. And, I think the majority of us do not recommend it, but I say majority of us, simply because the test was not great. Since then, there have been better tests. And better tests, and the betterness again, like some of the data studies from earlier, is the betterness is in the details. And some of the I think I'm showing you one of the one with the strongest push in the doctor's office is this particular test. And it got to the point that Scientific American reached out to them to find out how much it costs. And I think this cost has gone up. And what Medicare pays for out of the $12.50 is the measly $18. It's even less than the 20, but I figured I wasn't going to find a 5 and a 3 ones. So Medicare pays $18 for it. So if you decide to order this test, or you decide to convince your doctor to order this test, you'll be responsible for 99% of this test. And the hope or the hunt for a blood test for Alzheimer's disease is not new. It's been around for 25, 30 years. And even in the mid 20 teens, a number of us, you may recognize someone here, we're in the business of testing for these things. And then back then already, we knew that the blood test was just not good enough. But then again, science likes to repeat itself. Sometimes for better, sometimes not. And we're going through another cycle where the blood test is keen. And what the downside, it seems to be, and then this is a lesson we've known for 20 years now, the blood test for Alzheimer's usually correspond to a diagnosis of dementia, regardless of whether the cause is Alzheimer's disease or not. We don't quite understand why that is, but it's a known phenomenon. So in a way, if you go back and read some of those headlines, what the blood test is really good at is replacing the primary care doctor in detecting that someone has had dementia. It does not tell you whether dementia is due to Alzheimer's disease. And some of the recent tests, even though they've improved in performance, there are a lot of caveats. Some of the risk factors for Alzheimer's disease themselves independently increase the blood test values, even if you don't have Alzheimer's disease. This is from the Mayo Clinic study on aging. And if you have kidney disease, you're going to have very high levels. You're going to have a lot of false positives. If you had a stroke or had a heart attack, and again, you're going to have a false positive a test that can lead someone to believe that you have Alzheimer's disease when you don't. These are some of our work that's coming out soon. And again, it confirms that number one, the degree of dementia matters. The more severe the cognitive impairment, the higher the blood protein levels, regardless whether the cause is Alzheimer's disease or not. And what I also don't show here is importantly is that there's actually a race-based difference. And then this is a test that may actually worsen health disparities. So this is a test that needs to be used with caution. We are certainly absolutely for further development and refinement of these tests. But again, these tests are hardly ready for prime time, especially in the primary care doctor's offices, and even less so in a direct-to-consumer type of testing. So here's just a comparison in terms of the spinal fluid test and blood tests and what people are willing to do and not willing to do and what they actually do or don't do. And again, I've consulted with my colleagues up and down the Highway 90 corridor, and none of us is willing to give someone one of the new Alzheimer's medications on a positive blood test. And I think that that's a consistent message from the doctors and scientists who are experiencing treating these diseases as well as working on the scientific aspect of this. So we're always happy to hear from you. We have multiple studies that are recruiting at the same time, some national, some local. We have a very convenient email address at Rutgers. It's memory411@rutgers.edu. Somebody, actually multiple people, myself included, are reading the email on the other end, and we will help sort the email to the right audience. And so if you have a clinical question, we'll forward to the clinical people. If you have a research question, we'll forward to research people. If you're looking for other forms, other speakers and talk about other topics, and we will redirect them to the right people. So with the remaining 5 minutes, I know it's not enough time, but remaining 5 minutes, I want to see if anybody has any questions that I can answer.
I'm just warning, everyone's been muted, I think. So if you have a question, unmute yourself and ask it.
Okay, can I ask a question, please?
Please.
You mentioned smoking is very much a detriment, but how about all the new smoking ideas? That seems to be just as bad.
We don't know. We
Okay.
don't know. And this is a disease of older age. So the people who are vaping and they're
Yes,
generally
yeah.
younger age. Once they get to the older ages, we'll find out. And it's very much like, new diseases and new exposures. We don't know the long-term consequences until enough years have passed. But I always say, especially in the audience, but not just this audience, I say it elsewhere too. A lot of times you don't necessarily need science to tell you what your mother can tell you. Should you be vaping? No.
Yeah. Okay. And for example, the children nowadays, all they do is down the computers or they're texting. This is very sad because it's also making them isolating, which is also not good. I mean, they don't play anymore. It seems outside with each other. They all are on the couches with their little computers.
I fully agree. And then I think that's something that we need to work with the schools on. And because, when you look at a kid's time, there's so much time spent in school, and all the schooling is now computer based.
Yes.
And the neuroscientists, the developmental neurologists, we've had very little say in this. It's kind of thrusted upon us, and the long-term consequences were, again, won't be evident for another few decades.
So we won't know in our lifetime. Okay.
No,
Thank you.
and then the other thing you talk about, well, these are what we call emerging stressors. And the other one is microplastic. You probably saw in the news today or yesterday
Yes.
that each of us has, a significant amount of plastic in our brains now.
Yes.
And one of my colleagues at Rutgers likes to say that each week, each of us eats a whole credit card worth of plastic.
Horrible.
And we can't fix that ourselves because it's in the air, it's in the water, and that again, that is something that requires policymakers and other interested party stakeholders to come together.
Thank you. Thank you. Okay.
Thank you. Lisa?
Yeah, I mean, for the treatment, have you looked into that the ultrasound that was on 60 Minutes a few months ago? Is that still around?
Yeah, and we've got a lot of inquiries following the 60-minute airing, and then so the drugs get in. So the drugs they're used for those who may not have seen it. The idea is to pair the infusion drugs that slow down Alzheimer's disease with ultrasound to the brain, which open up the barrier between the brain and blood. And then so those drugs get into the brain just fine. You don't need an ultrasound to open them up. What's exciting is the next generation of drugs that they actually have a little carrier that comes with the drug so that it kind of tricks the brain into picking it up. So instead of monthly infusion or twice monthly infusion for 18 months, the hope is that with two doses, we will be able to clear the plaques in the brain. But that is what again, and I'm going to emphasize that's next generation, not even next generation. It's next.
Okay.
Thanks.
Other questions?
No.
This is Monica. I don't know how to put my hand up.
Oh, I'm sorry, I didn't see.
Has there been any studies done on hereditary, if your parents or your grandparents have Alzheimer's? Is there anything that shows that you will have a greater risk?
Yeah, so I'm a numbers person at heart, and I'll tell you kind of the number story. So already, in the Lancet Commission, they said that about 45% of Alzheimer's disease is potentially preventable. And the geneticists also tell us that over 70% of Alzheimer's disease is genetic. So if you add over 70 with over 40, you get 110, 120. So something ain't right. And then so from a genetic perspective, there's a very small group of people with inherited forms of dementia. And they occur generally in the 30s and the 40s and up to the 50s. When dementia kicks in, regardless of cause, in the 60s and 70s, they're generally not familial. There's a lot of work on identifying risk genes that if you carry a risk gene, you have a higher risk. And that risk gene can be passed on from one generation to the next. But on the other hand, lifestyles are also passed on from one generation to the next. And then so if you look at the different lifestyles, they account for more of the risks than just from the genes alone. So it's a long-winded answer to your fate is not predetermined. And then there are a lot of things one can do to reduce your future dementia risks.
Thank you.
Any other hand that I don't see? I have 2 pages. You gotta holler.
Brenda.
Brenda.
Hi.
Okay. Hello.
Hi. So are you afraid your research may kind of come to a halt at some point with the new administration and the things that they're doing with who's coming in to take charge?
I think with every administration, there's that concern and fear.
Yeah.
And then again, I think it's the perception that research is wasteful. And then whenever a reporting is a soundbite, they find some ludicrous research, that probably has a role, but is not the majority of the biomedical research happening. And then as we kind of I showed you on the first slide, it's $50 for care and $1 for research. And this is a very costly group of diseases that they're absolutely worth the investment. And we've actually made many full returns on investment, but it's an easy target. I think that at the same time, it certainly creates a lot of anxiety for scientists and doctors working in the field, especially young ones who just enter the field, who may not get their first award, who may not be able to continue their career in science. So those are worrisome things. So we are, looking out to more philanthropic sources for support, at least in this period of uncertainty.
Okay. Thank you.
And speaking of which,
Yeah,
I'm going
hi.
to share. I'm going to share
Hi.
my screen now. All right, and if you can see what's here, if you want to help contribute to this fine work, your check should be made payable to the Rutgers University Foundation. Put on note on the check, it's Robert Wood Johnson Medical Center, Dr. Hugh Cognitive Neurology Research Fund. And if you can fit that on your check, you're a better man than I. But make sure it's got Dr. Hugh's name on it. I'm sure it'll get to the right spot.
And please drop us an email so that we can thank you. Despite our repeated efforts, the foundation has a challenging time keeping track of donations. So we want to make sure that, your donations are getting to the right places.
Excellent, excellent. Okay, thank you so
Thank
much.
you.
Yes, thank you for having me.
Thank
Have a
you very
wonderful
much.
one night.
Appreciate it.
Thank you.
Thank you very much.